And welcome back to JKLIVE. What an interesting discussion we're having about COVID-19 and the latest. Everyone's asking all the right questions, and we have the right experts here in the house. Dr. Lois Ombajo, she's an infectious disease expert at the University of Nairobi and the head of the infectious disease unit at the Kenyatta National Hospital. And of course, our favorite doctor, Dr. Gigi Githinji, Group CEO, Amref Health Africa, and also on the commission, recently constituted commission, Africa 19 response team headed by South African President Cyril Ramaphosa. Congratulations for that, by the way. Well done, well done. Look, you, for the longest time, Dr. G, have been talking about herd immunity, right? Trying to achieve this herd immunity. There are places that people go, like, let's say, Kibra, Madare. No one's wearing masks, no one's social distancing, and the numbers are not rising. Maybe they already have herd immunity in places like that. We don't know.
Yeah, we don't know. And also, you know, there are many factors. It could be that within that community, they have achieved herd immunity. But also remember that these are significantly younger populations in some of these areas. Have you seen people leaving Kibera, going to industrial area in the morning? Yes. They walk 10 kilometers a day, you know? So that the younger nature of the population there could also contribute to why you're not seeing rising deaths and that. So they get it, they infect each other, and then they develop some immunity. But that's not to say that there are no vulnerable people there. And that's not to say that they're still not infectious to infect other people. So you have to also still insist on the measures, even then. So everyone must follow the same public health measures, irrespective of whether you suspect you're infected or not.
Dr. Lois, you agree? I mean, government wants to achieve herd immunity by next year. What if the virus changes by then? Because it keeps mutating, right?
So the concept of herd immunity is that most people have some level of immunity, so fewer people will get infection, and when there are fewer people who are infected, fewer people spread. Herd immunity is a concept that in infectious disease has traditionally been achieved by vaccine, not by letting people get infected. Because if you hope to achieve herd immunity by letting people get infected, then people will die, you know, and you don't want to achieve herd immunity for the remaining few. Right. You want something that protects the majority. So really it's about getting vaccine into as many people as possible so that most people are immune, fewer people are sick, and there are fewer people to spread the disease around. So really, as these vaccines come along, the task will be how to roll it out as fast as possible. And of course, hoping people now will accept it to get, you know, to get the vaccine soon and not wait until the last minute to rush in. Yeah, like typical Kenyans, right?
Lastminute.com. Okay, Dr. G, if we do attain that herd immunity, how long does that vaccination period last? I mean, will we have to go for annual jabs after that? Will it be like the yellow fever? You know, will it last a few years? I mean, the things we don't know, but what do you say?
We don't know. Actually, the answer is we don't know because we've not had the virus long enough. We've not had vaccines for long enough. There are cases going on. We talked earlier about some people thinking a third dose might be useful. We decide, you know, we were discussing here, it may not be useful until everyone has a. So for now, we don't know whether it's going to be annual, biannual, we don't know. So I think we just have to wait. You know, we know the flu vaccine is annual. We know that yellow fever used to get it every 10 years. Then eventually WHO said you don't even need that 10-year booster. So it's a lot of things up in the air. Maybe Lois has more recent data. I don't know.
No, if you think about it, the longest anyone has had this vaccine is probably just over a year, which means we don't have enough experience to tell whether it will last beyond a year. So I think it's about waiting. As I said, there's so much still to learn about this disease that the things you say tomorrow, by next week we come and say, oh yeah, we were wrong last week, this is now what we know. So there's a lot of learning to happen. As I said, only probably just 1 year is the longest anybody's had the vaccine, so we still have to wait and see.
Dr. Githinji mentioned a moment ago, Dr. Lois, that we're going to be spoiled for choice with lots of vaccines on their way. Are we working on anything ourselves? Any chance of us working on a vaccine ourselves?
So, I mean, there have been some clinical trials looking at vaccines from elsewhere. There are many scientists who would want to work on vaccines. One of the things that that for a country to produce vaccines is that there has to be investment in research. There has to be investment in top-of-the-range labs. And if we do not have that, then we cannot expect to churn out vaccines. So government has to invest in research, has to support scientists to do the work before we can get to a point where when a new disease comes, they're already releasing a new vaccine. So it will probably be a while before we have developed our own, but hopefully that will come at some point.
Yeah, and in the meantime, if what Lois is saying, we haven't invested, you then have the other channel of knowledge transfer or intellectual property licensing. So we have seen countries, even Kenya, is looking at, what we call the messenger RNA. Rwanda is looking at it. Senegal just opened, planned. Well, I saw Uganda. I'm not too sure what is going on there, but I saw they also launched a plant where they say they're going to manufacture vaccines. But that window is about licensing. So you have Pfizer that says we are going to transfer our knowledge to this country under a particular arrangement, and you manufacture under license. Therefore, you don't have to do the R&D, you just do the production. So that's also another window that Kenya, Rwanda, and other countries in Africa are looking at. South Africa has already started manufacturing J&J under license. India manufactures AstraZeneca under license from AstraZeneca. So that's the other opportunity.
Before the break, Dr. G, I mentioned that the UK was removing all restrictions next week. Is that worrying?
It's unwise, I think. I think from what we've seen from Netherlands and what we are seeing from elsewhere, I think it may be, if they want to ask me, I would say do it gradually, don't lift all of them and then see what's going on. Because again, even here, it's about titrating. You dial down, you dial up. So I think any government trying to open up completely should use a dial down, dial up methodology so that you don't end up with a catastrophe. That would be my view.
I mean, one of the things that you'd hope for is that as you get more and more people vaccinated, people can move a little towards some concept of normalcy. But if you think about COVID and you want to reduce restrictions, it would be that everybody's vaccinated, and which is the safest area for you to open up? It would be outdoor, out in the sun, It would be where there's no crowding. It would not be in classrooms and in offices where there's little ventilation. So you would start by saying out there where there's no crowding, possibly you can reduce some, but it wouldn't be indoor, and you wouldn't necessarily allow large gatherings either. So it has to be, as he says, very gradual, thinking of what's the safest place where you can do away with some restrictions and watch that space for a while before moving on to the next one. But if you lifted everything at once, then you end up going back into lockdown because the cases will go up.
Speaking of lockdown, before the break we did discuss, I haven't forgotten.
What determines
the case
lockdown?
for, yes.
So usually what happens is this. When there is a surge in an area, you look at what is happening in this area. Is there a lot of community transmission? Which means as you walk into a community, you'll find maybe 1 in every 2 or 3 people you meet is possibly positive, which means anyone going in there will get it, and anyone coming out of there could potentially spread it. So that's what you're looking at. How much community transmission is there? In which case you want to contain it within the community without spreading it out. And even there, it's not to contain it so that you just mingle and all of you get infected. It's within this community, let's also put extra restrictions so that you reduce the number of people who get sick. So for example, in the past, we've had instances where Nairobi was locked. We didn't have a proper lockdown. When I hear about the lockdowns in the European countries, you're not allowed to leave your house unless you've informed the police that you're going to the pharmacy, for example. So we didn't have a proper lockdown. But at that time, the positivity rate in Nairobi was very high. It was thought the community transmission was very high. So one, you wanted to protect the people outside of Nairobi from us Nairobians, so they shouldn't come in, but people in Nairobi also shouldn't go out. But then within Nairobi, you must do something to contain it. So that's when you say, we'll close places where people laugh loudly without their masks. Those places. We will, encourage people to stay home and not to go into the office, and we'll reduce gatherings. We'll say even religious functions and funerals and weddings. And the essence is that within this lockdown area, you also put even more restrictions so that spread is reduced. So that when you open up, there are fewer people who are infected and can mingle with others. So usually it's an issue of how much community transmission there is.
And right now in Western, is there cause for concern about it spreading beyond?
There was a lot of cause for concern a few weeks back after a famous ceremony. So then that was a time when you'd potentially consider possibly putting in extra restrictions. Of course, restrictions come with a lot of other issues, you know, the economic issues, and, you know, people have to survive. Yeah. And sometimes those decisions, the decision to put very severe restriction has to be balanced against how people will survive. So that sometimes determines what level of restriction is put in place.
Yeah. Dr. G, previous lockdowns, because like Dr. Law said, they weren't really locked down, curfews, did they work?
Oh, yes,
they did.
They have worked. You see, I think that the concept you need to explain to people here is that lockdowns are not a solution to the virus. Lockdown are a solution to saving lives by protecting the health system. So we don't do a lockdown so that the virus goes away, because people had this concept that when you do a lockdown, by the time you open, the virus is gone. It's not gone. The reason to do the lockdown is because that surge, if you have enough oxygen, enough hospital beds, enough critical care staff, you can wait for the surge to keep going, because you can actually admit everyone who needs to be admitted, get oxygen and go home. The challenge of a lockdown is when it starts to overwhelm the health system. In the last surge that we had, we started to see people traveling county to county looking for ICU beds. Then you must lock down. And you're not locked down to chase the virus. You're locking down to reduce the rate of infection, calm down so that you're able to manage the people who need the care. So even now, if we go to another one in end of July or August, it's not going to be that this is now the solution to the virus. It's still going to be to protect the health system, to take care of the people who need care. And you'll keep doing that until you vaccinate everyone. So if you don't vaccinate everyone, we'll keep having a wave, you lock down, it comes down, then you wait again, it goes up, you lock down again, and you lock down at the point at which you think your health system is in danger of being overwhelmed. Yeah.
The president the other day was talking about by the end of the year there'll be how many people
vaccinated?
10
million.
By the end of this year?
Yes.
You're on the task force team?
It's biting an elephant, but we will try.
And then by mid-2022 or end of 2022, there'll be enough people to
vaccinated.
Yeah, if we follow that schedule, it should be, because if you're talking about 10 million people,
out
and
of
you're
1
talking
million
adult
so far.
population, and the adult population in this country is maybe call it 25 million, because you carry about 18 or so, then that means that if you'll have vaccinated half the adult population, or close to half. Now, so the challenge is the vaccines will be available, because if we get 13 million J&J in the single dose, you have enough for 30 million people. And then we already have some AstraZeneca coming. We have 2 million of Pfizer coming or so. So the vaccines will not be a challenge. The challenge is going to be the throughput. How do you get 2 million people vaccinated with one vaccine in a month? 2 million people each month. You can divide that by 30 and you see the challenge. The highest vaccination we had in the last cycle was, I think we hit 40-something thousand, maybe just about 50,000 a day. So we are basically looking at how do you more than double that per day to hit the president's target. But that's an executive order, so people have to work towards it. And I can assure you that the National Vaccines Task Force is doing everything possible to ensure that that target is met. But it's going to include, number one, campaign mode vaccination. You cannot hit that number of 150,000 a day by just expecting people to come to the hospital, because the health workers are busy. So you can't bring in 150,000 people into the health system additional to that. So we are thinking you may need alternative vaccination centers, okay? But then you need to also mobilize people. In some areas, you may need to do outreach. You may need to go to where the people are. And that's how we achieve polio targets. That's how we achieve measles targets. We achieve them through campaign mode. So that it has to be a critical part of getting the 10 million target.
I was about to say, go door to door like they did with polio.
Probably. Have it in the community, have it in the chief's camp, have it in the churches, anywhere where you can get people. Or
deploy our very efficient military. They do a good job.
Okay.
We have evidence. We have evidence.
There you go.
So that they'll do a good job?
Yes.
Okay. With vaccines?
Questions on the magic wall, that plenty coming in thick and fast. You guys. All right, on Twitter, Angela Lumumba is saying, how will the new evidence linking the Johnson & Johnson vaccine to Guillain-Barré syndrome, GBS, that you talked about, affect Kenya's orders of this vaccine and the use thereof? Referring to that article in the New York Times.
Yes, so the vaccines have been ordered and they're coming in. As I said earlier, there have been some reports of GBS, and this is not unique to COVID vaccines. Even with other vaccines, there have been some association with GBS. The reports so far are few compared to the number of people who've been vaccinated. So that tells us that the risk is still very low, but we'll have to be vigilant to observe. As the vaccine is rolled out, we'll have to tell people about what are the symptoms that you look out for so that you can report, because many cases of GBS are successfully treated. So it's really about being vigilant. But again, just to reiterate, the risk is very, very small. The risk of dying from COVID-19 is a lot higher. So many times what we do is you compare the risk to the benefit. The benefit of getting the vaccine is so much higher than the minimal risks that may be there.
It must be difficult for you, Doc. This disease is like breaking news. You know,
every day.
Yes.
Right?
True.
Every day you have something new. And I would like to add to that that, you know, every single vaccine platform we've had has had an issue or other. You know, we started with AstraZeneca, people saying, oh, blood clots. We haven't seen people dropping off because of blood clots, but it is still a significant issue that needs to be checked. Then you come to Pfizer and Moderna. What's coming up? Myocarditis. You know, there are claims of some few people getting some inflammation of their heart. Then you come to J&J, then you have the GBA. So it is just ensuring that any possible risk is extremely, extremely rare and reducing that risk. But it's all of them will have a risk or other.
Right.
So look at the positive side, saving lives.
Very good point. Patrick is saying, with the second dose administration ongoing, is it time we started studying severe COVID-19 trends among the vaccinated versus the unvaccinated?
Yes, that's an excellent thought, and that's the only way you begin to say that if we have a new variant, for example, is the vaccine still working as well as it was when we had a previous variant? So that is excellent, and as we begin to have more and more data on those who've been vaccinated, it's something that we really should be looking at.
Yeah. Dr. G? Agree?
Yes, absolutely. And I think, I look forward to our colleagues, our experts, like Dr. Lois is saying, if you just looked at the patients who are coming, just look at, questionnaire. Are you vaccinated, not vaccinated? And then after that, check. So I think it's a really good question.
It is excellent.
Many countries are doing so, by the way. That's how we know in the UK, in the US, I was seeing data saying only 12%, I think, of the people admitted had some, had any form of vaccination. So majority of the people being admitted had no vaccination at all. So we need to do the same studies here in Kenya.
Yeah. Alex Corio is saying, one question for the docs. What's the point of observing COVID-19 protocols if someone is already vaccinated with both doses? I'm sure you get a lot of this, Lois.
Actually, when I came in and sat in the waiting area, the gentleman there wasn't wearing a mask. So I asked him, "Aren't you wearing a mask?" And he says, "But I'm vaccinated. Don't you trust these vaccines?" So, one of the things, as we've said, is that we've only had COVID for over a year. There's still a lot that's to be learned. We know that the vaccines protect you from severe disease and hospitalization and death. We still do not have information as to whether it protects or what level of protection it gives against just having asymptomatic infection. So when you're wearing it, you're also protecting other people. In case you got asymptomatic infection, you're not spreading it to other people. But more because there's still so much that we're learning. So as more and more people are vaccinated, then we may begin to drop some of those restrictions as we discussed earlier.
But in the meantime, Dr. G, keep that mask on, right? You keep telling people.
Keep the mask on, keep the mask on, keep the mask on. I think there's no other way of saying it.
And I still refer to your Swiss cheese analogy.
Exactly.
Right?
Yes.
Mask, sanitizing, washing hands, social distance.
And now vaccines. So
and now vaccines.
Exactly. Everything goes together.
Very good. George Muga, could Dr. Gigi explain to safe disposal of surgical masks? Seems like it's the new litter in the streets. Well, good point.
It is a really critical question, because what people must remember is that a mask that has been used is hazardous waste. It's medical waste. You've been to a hospital, you see all waste from patients is handled in a particular way. Now, we forget that actually we are handling medical waste. So when you have used your mask, it could have pathogens or bacteria or viruses that could infect other people. So disposal of that mask, other than the ISO, environmental, issue, you're also putting other people at risk. Because remember, when you dispose it, somebody else could come and pick it and use it, because maybe they didn't have money to get another one. Yeah. So we recommend that you dispose it the way you dispose something that's hazardous. So burn it, cut it, or seal it, or put it somewhere where no one can reach it. But dropping it on the streets is completely uncalled for, it's reckless, and you're actually putting other people at risk.
Yeah. Very good point. As well. And the kids are swapping masks, Doc.
It's like lollipops.
Yeah, it's better than lollipops, right?
Your mask looks better than mine. So. Oh, what do you do?
Just make sure they have a mask. At that point, it's just important that they have a mask.
All right. Daniel Joro says, double masking. Oh, any additional benefits? Information? I've seen people with double masks, actually. Any benefits, Dr. Lois?
So there was some data, I think this one came from the US and it was released by the CDC, that suggested that double masking may have some benefit over and above a single mask. But this is largely for people who are in the highest risk areas. So that doctor or nurse who's handling patients who may have, because you're seeing so many people who may potentially be infected. Out on the street is probably not useful. You can do with a single mask.
Right.
Yeah.
And people who had that big shield on top of the...
Oh, yeah. When we first started treating COVID, we wore those things. They were hot in there, very, very hot. But there was a lot of fear. Yeah. There was a lot of unknowns, and we went to space on patients. But as time went on and we became a little less fearful, there was a little more data released. Yeah. Now we're not... Yeah.
You don't need the space suits.
In some facilities, especially if you have patients who are in the ICU, where, there's a lot of procedures, then there may be a little more protection. But outside of that context, we don't do it that much.
Jeremiah Kadioki says, elaborate on the difference between AstraZeneca from India and the one being used in Europe. Why is it the vaccines are expiring so fast? Donations to Africa, especially mostly those expiring within 2 to 4 months. Dr. G?
Well, so the AstraZeneca being manufactured in India is the same AstraZeneca as being manufactured in Europe. The difference is the manufacturer. So the one manufactured in India, by the way, by the world's largest vaccine manufacturer for children, 1.5 billion vaccine doses a year, meaning it's a reliable source of vaccines for even our own children, is under license by the same person who did the R&D or the research and development for the one being manufactured in Europe. Now, what happened is that when they started, now when you get the license, you have the license to also brand. You can call it your name. So they called it Covishield. It's the same vaccine. When in the in Europe, they call it as Vaxzevria. So they are just different brands of the same thing. So the difference is the manufacturing site, okay? The next issue around, expiry. All these vaccines have a life, have a shelf life. Just like all medicines, food have a shelf life. For the vaccines, most of them have 4-6 months, depending on who is the manufacturer. So by the time you get the vaccine, it's already maybe taken a month or 2 months, so you have only 4 months of life remaining. And remember also that part of the vaccines that are being that we are using now in other countries are donations, meaning they were actually, like South Africa had vaccines for a long time, then said to send them to DR Congo. Then South Sudan had vaccines, they couldn't vaccinate all of them, they sent us 72,000. So by the time they were waiting to see whether they can vaccinate, they have also lost some life. What to remember is that as long as the expiry has not reached, even if it's a day before, it is still safe for you. Yes.
We also got some vaccines from Congo, didn't we?
No.
No, they went elsewhere.
They went to their regional, their neighbors. So we got some from South Sudan.
Oh, okay. Yes. Okay, gotcha. Just checking. Peter Wanyoike, we saw stadia operate at maximum capacity, fans not social distancing and with no masks. It is such countries have acquired absolute immunity to COVID-19 for the authorities to allow such huge crowds. I guess he's talking about the Euros, right? You saw those crowds.
Yes.
No masks, no social distancing, nothing. How come? And a few months ago, they were under lockdown. Explain to me.
I think It's several issues. One, people were tired, and this was an opportunity to get out. Two, there was also this false illusion that, you know, we are vaccinated, let's get out. But there was also probably rapid lifting of many of the restrictions. As we said earlier, it needs to be phased, done slowly, as you observe. And one of the things that a lot of the European countries are seeing now is a steep surge in cases. So is it got to do with some of, you know, the amount of gatherings that were seen, or many other factors that may be there? So basically what it tells us is that even when the time comes to open, we cannot afford to be reckless about it.
But Dr. G, you saw those crowds. Were you like watching TV and saying, is this Wembley, or is this whichever stadium that was crowded? Yes,
I was just seeing, you know, Dancing with the Devil, really. That's what I saw. Like, as she's saying, because these people are vaccinated, you know, UK has vaccinated probably just above 50%. So you don't have 100% vaccination. They may even have insisted, if you're vaccinated, you can't come here unless you're vaccinated. But we saw people breaking through to enter the stadium by force. So the risk exists, and I think the only proof of the pudding is in the eating. Like we've seen in Netherlands, they opened up everything. Now they're 500% up. We don't know what's going to happen in the UK, and they may regret. So let's just wait.
Like Dr. Lois said, phased. We don't. But maybe they were, like you said, they were cooped up for too long.
They're tired.
Cabin fever, they call it.
There's fatigue.
Rizzy Kim is saying, is it possible to get severe COVID-19 after being fully vaccinated? Is there any data on cases of severe COVID after vaccination? Lewis?
Is it possible? So one of the things from the data that we have from the vaccines is that it's almost total protection against severe disease and against mortality. Having said that, occasionally you'll hear of isolated cases, so people who had been fully vaccinated and then they get COVID. Most of those have been mild. Occasionally we see some that are severe. I think there are very few deaths reported so far. But as we said, some of these things we learn along the way. But at this point, it seems that most vaccines will be protective. But we know of cases where people have gotten severe disease and even died. Remember, none of these vaccines markets itself as 100% protective. It reduces the risk of severe disease and mortality. And until we know all that, it's probably part of the reason why we need to keep our masks on for a little longer.
Double mask. By the way, do we have enough oxygen in the country?
We have, there's a committee that I know of at the Ministry of Health. Are you in that committee? That has been working day and night to try and avail oxygen. Remember, availing enough oxygen to every hospital requires a lot of infrastructural input, a lot of logistics. So that's work in progress. We can't say it's enough. But I think this, at least we're seeing some steps towards getting more and more facilities supplied with oxygen. But the one thing I have to add is that it doesn't matter how much oxygen you have. If we all got sick, that oxygen would never be enough. So we always have to make sure that we don't have too many people getting sick at any one time.
Dr. G, are you on the committee?
You see...
Are you on the committee?
Yes, I am.
Okay.
You wanted to say no.
So, you see, so... you know, she's absolutely right. The oxygen capacity for this country for the longest has been at a particular level. It's not been optimal. You still looked for it, but it was at a particular level. COVID has taken that up 3, 4, 5 times during a surge. So as she says, if we all got sick, then we don't have enough oxygen. So do we have enough oxygen for a surge? No, because we don't know how big the surge could be. Now, let me then look at some of the other areas we need to look at. We need to look at one, investing in more oxygen. And how do you do that? You know, we have seen counties building oxygen plants. We need to produce more liquefied oxygen, which is the purer form. So there's a lot of investments that are going in. And I know we have a lot of investment now happening across all counties. But the next thing is how the oxygen is used. In Kenya, a lot of the oxygen is single patient, single tank. So you see, you go to the hospital, you have 10 patients and you have 10 tanks. And all the tanks are this size because we don't have proper oxygen delivery mechanisms. Because what you need is one tank can serve 10 people okay? Meaning that with the 10 tanks, you can actually serve 100 people. So now you have enough oxygen. So it's also about delivery. And how do you do that? By building systems, piping, that allows you to connect your tanks to one input, and then you have multiple outputs. So again, work is going into that area to ensure that we expand the capacity, not of the oxygen, but of the oxygen delivery, so that you can serve more patients. And the final one, what I was discussing with Dr. Lois before, is about what we call rational use of oxygen. That you need to know how much oxygen to give for which patient. You know, COVID patients' demand can go up to 20 liters or even more, you know, per minute. The question is, who needs 20, who needs 15, who needs 10, and when do you step down? So if you don't understand that, then you could actually end up using more oxygen than you need per patient. And Dr. Lois is involved in a committee that is training on that.
Work in progress. So, yes. Explain to me real quick, how did India go from this many number of patients a day positive down to so minimal? What happened in between?
How did they control?
Yes.
So I think that's something we've noted in multiple places. We have these surges that come down naturally most of the time, either because as more people get sick and more people die, there's also self-preservation. So more people will keep away, more people will stay at home. So already people begin to take precautions when they see so much death. But there's also this element of saturation. You've infected almost everyone you could infect, and so most will recover, because, you know, most people who contract COVID will be asymptomatic and recover. So the natural course is that it will go up, but it will definitely come down at some point. And in control measures is to control the peak, so that it doesn't go too high, but also help it come down fast enough. And that's really why measures are put in place from time to time.
Exactly.
Yeah.
And remember that, you know, generally, if you look at population dynamics, it's about the same people who interact more often, you know. So there are people who come to the city, or they're in the city. So they're around the same people. So you can consider this as multiple small forests, but are not connected. So when you burn one forest, then you have a surge. And when it's burnt out, there's no one else to infect in that cohort of people. So it dies out, it's a saturation, until it crosses and catches another population. And then you have another surge. When it burns that forest, it goes. That doesn't mean there's no other forest to burn. You just need the link to happen. And that's what people don't understand, that the fact that it's gone doesn't mean there are still no susceptible people in the same population. There are, just that they were not as connected as the first cohort. So it's this kind of movement.
Very good point.
Yeah.
Very clear. Thank you for that. Alex Omari, please ask my boss, Dr. Gigi, to tell Kenyans what a fleeting contact is and why the Delta variant might be your next door neighbor.
Thanks, Omari. Now, you see, with the previous variant or wild virus, we defined a contact as 15 minutes of contact with somebody who is infected. So if you had less than 15, you are thought not to have had an ideal contact. So the fleeting contact is actually now saying that if somebody has a Delta variant, you don't need 15 minutes. Just passing by and being close to them is enough to get you infected. Meaning that even within our protocols, we need to actually redefine contact, because contact is no longer 15 minutes with the Delta variant. That's what we are talking about, a fleeting contact.
Whew. Just like that.
Yeah.
Anthony Langata is asking, how many COVID-19 variants are there in Kenya? Dr. Lois?
So there are very many variants, but we sort of classify these variants into what we call variants of concern, or variants of interest, or other variants that have not achieved the threshold. So variants of concern are those ones that have been shown to have certain characteristics that make them more deadly. So either they can be transmitted faster, or they can cause more severe disease, or they may not be controlled by vaccines. So of those, there are a number. One was the Alpha, which was initially reported from the UK. There was a Beta, reported from South Africa. There's a Delta first reported from India. There were variants first reported in Brazil. So those are variants of concern because they are more easily transmissible. They may cause some may cause more severe disease. Then you have variants of interest that have been shown to cause some community transmission. You know, they've already been told that it's shown that they can cause transmission within the community, but they've probably not yet been shown to be more easily transmissible or more likely to cause severe disease. So those are variants of interest. And those are the ones you'll hear, Lambda, that was reported somewhere in Peru, Theta, Zeta, you know, the alphabet letters you can think of. So there are a number of those variants of interest. But having said that, we also have other variants that haven't met that threshold. So even in Kenya, you'll have certain variants that are not either of interest or of concern. The ones that are most concerning are the ones of the variants of concern. So the alpha, beta, kappa, delta. Yes.
So sounds Greek to me.
It is.
It's all Greek.
Wow, you guys have made a lot of things, put a lot of clarity tonight. Thank you so much. You've answered a lot of our questions. It's only fair we get some closing thoughts going forward. And someone keeps asking the question, is there fear of a lockdown if there's a fourth wave? There's that one question. And, you know, you kind of answered it, but is there fear?
I will say it again, that if the cases start rising, and we have seen they have started rising, we have seen evidence. If you look at the 7 moving average, you'll see, you know, there's a little bit. And there is risk to the health system because the number of people being infected and being identified with symptoms are more than we fear the health system can handle. There will be a partial lockdown. Kenya has never had a lockdown, Dr. Lois says so, but there are measures. But the question that people keep asking, this curfew question, I don't think I answered it clearly. Is the curfew useful? Some people ask, does this virus only travel at night? The thing is to watch those things that Doc talked about, that the virus will transmit most easily when the following conditions are together. 1, there's crowding. 2, there's close contact. 3, in a closed space. Those 3 C's. And finally, T, the time of those 3 C's together. Yeah. That's why you see the government saying reduce the contact time for the sermon in church. Instead of 1 hour, make it 30 minutes.
Right.
So it's about 3 C's plus a T.
Again, crowding.
Crowding, in close contact, in a closed space, those 3 C's, and then you add the time. Now, with what I was talking about in terms of the fleeting contact, time may even become less, okay? So those 3 C's and a T. So when you look at those, then you design your lockdown measures. You say, we are going to start locking down or reducing time in those places where the 3 C's are likely to be together. And what places are those? We know. It's the social places. Yeah. Crowding, close contact, close spaces. So those things will have to come if you have a surge. And those places that those 3 C's plus the T is high come together, those places will have to be locked down or closed or timing there reduced, whatever measures the government decides.
You know, I'm so glad you mentioned about the virus traveling at night. Everyone keeps asking that question. Yeah. Does it only travel at night?
Funny. Science of contact, crowding. Yeah.
3 C's and a T.
Yes.
Dr. Lois, closing thoughts.
So some of the observations that we've had managing patients over time is that many people get infected when they're with the people closest to them. So it is that family gathering, it is those friends coming together. So it's not, they've not gone to Wembley, you know, they haven't gone to a big stadium, but they've had a family function together, they've had friends together. So it's in those places where people are comfortable. And the main thing to tell people is it's good to be with your loved ones, just put certain measures in place. Meet in an outdoor place, wear your masks, don't drop your guard because you're with people you know, because unfortunately the virus doesn't know that that's your sister. You know, the virus doesn't keep your genealogy to tell that that's your grandmother or that's your uncle. So even when we're the people that we love, let's try to do most of our things outdoors if possible. Let's wear the masks when we can so that we don't transmit infections within families. And we see many situations where several members of one family die or get sick. It's because they were all together without taking any precautions. So if people would watch those small things and take precautions in those places. And it's been a really long journey. I think everybody is tired, but we need to survive. You know, we need to be telling this story next year. So we have to take care of ourselves so that we can live to tell this story.
And there's light at the end of the tunnel?
There is light at the end of the tunnel. Sometimes it's a bit dim, but it's there.
It is there. It is
There's light at the end of the tunnel.
Dr.
Yes.
And there's something, you know, you've reminded me of an incident I had recently. So I go to a gathering, I have my mask on, and of course you're, and then I go to do this to a guy, to somebody, he says, no, maybe it's in a corona. You see, like, and that's happening a lot. That people are like, when you do this, you're implying I'm unwell. Right. Shake my hand, I don't have corona. So we must watch those things and say, even if you don't have, I don't want to give it to you. Yeah. So don't shake hands. It is this small thing that we have dropped our guard that's going to increase. Yeah.
You know, that's a very awkward moment. Huh? You know, you put your fist, you put the hand, you don't know what to do.
It's in a corona, you know. Like
I have felt that, faced that a lot.
Exactly.
By the way, did you ever get to speak to your 84-year-old mother? Did you, or are you still on video phone, or have you been in touch?
She got her first dose of AstraZeneca, and this is important. People have asked me, have you been vaccinated? Yes, I've been vaccinated. Has your mother been vaccinated? My mother had her first dose of AstraZeneca, and she's going for a second dose tomorrow. She's 84 years old. So now, you know, there is a bit more interaction. Of course, all protocols must be observed. All of them must be observed. In her house, we still have sanitizer, hand washing, and you still have to wear your mask when you're in her house.
My 84-year-old mother is watching you right now. What do you tell her? She's a little resistant to getting the vaccination.
Has she gotten the vaccine?
No, yet.
Okay.
She needs to get it. She needs the vaccine. It's going to free her life.
Yeah, tell her it will be easier for her to interact with her grandchildren and her family if she gets her vaccines.
Exactly.
Very good point. Yeah. See? She just heard you.
That's it.
When I tell her, she doesn't listen. Dr. Loizo, thanks so much for your time.
Thank
As
you
always,
for having us
you guys are great. Dr. G?
Thank you.
And congratulations on the new appointment.
Congratulations.
It's just more work.
Congratulations either way.
You.
Well done. Great job.
Thank you very much.
Let me just finish over here and great job. Thank you so much, folks, for joining. Remember, Jeff Grenega Live is powered by Standard Chartered. By the way, Standard Chartered recognizes that owning a home, a holiday home, or investment property is a dream for many Kenyans. However, the cost of owning a home is a deterrent for many, and even for those already committed with mortgage loans. It can be a financial strain. Now, how does Standard Chartered Priority Banking do this? Well, I'll tell you very easily. Take a look at this. Take a look at this. Here we go. Here we go. Discounted mortgage interest rate at 11.9% per annum for new applications submitted and approved between now and October the 31st, 2021. And, excuse me, zero valuation and legal costs to move your mortgage loan to Standard Chartered Bank. How about that? Yes, indeed, folks, Standard Chartered. Join Standard Chartered Priority Banking, where your priorities get our priority. Thanks so much for being a part of the show. I hope most of your questions were answered by our great experts over here, folks. It's great and important to have this conversation every once in a while, just so that as a nation we can know where we're going moving forward. Thanks so much for being a part of JKL. We'll see you again next week, same time, same place. Good night, good luck. God bless you all and stay safe. Mom, are you listening? Stay safe. JKL.